Okay, guys, on to tonight's teaching from our FRCS mentor group. I hope you can all hear me well. Thank you everyone for attending. If there are any issues, technical issues, please write me a message on the chat option. If you have any questions also, please write me a message on the chat option, or next to your name, you could find an option to raise your hand. So please raise your hand if you have any questions tonight. We have two sessions, all upper limb theme. The first session will be delivered by David, and second by Kashif. Very good, they have prepared very good talks, very specific FRCS talks, and we're very grateful for the time they dedicated for this. So we'll have with us also Shwan, who will also be supporting us. Without any undue delay, I will leave you with the speakers tonight. Go ahead, David, please.
Thank you. So today I'm going to talk a bit about surgical approaches, and we're going to talk about the surgical approach to the shoulder. And specifically, I'm going to focus on two common ones which come in the exam: the anterior deltoid-pectoral approach and the posterior approach. Now, just some basic principles when you're thinking of the approach, which you can apply to any approach. I do recommend the book by Alex Trumpter. There'll be links on the Telegram group about this. But when you're talking about approach, these are the basic principles you should think about: the position of the patient, anatomical landmarks, the internervous plane or intermuscular plane in some instances, structures at risk, and if it's an extensile or a limited approach, and also some tips as well. And I'm going to focus on some pitfalls that can happen, particularly with the anterior deltoid-pectoral approach, and also one of the reasons why they talk about the posterior approach in the exam. So starting off, so the deltoid-pectoral approach, typically used in arthroplasty, anterior stabilization procedures, proximal humeral fractures. So it's very popular on the trauma table, as well as the sort of basic anatomy. I had it on the basic anatomy. Glenoid fractures and combined procedures. So in terms of position, so we have the classic beach chair position, as demonstrated here. So thank you to the AO. I've used some of their pictures. Pad between the shoulder blades, head tilted to the way, and access for fluoroscopy. Also, sort of knees bent, stop the patient slipping down and making sure they're secured. This position is more for an anterior humerus or mid-humerus, but some surgeons will come from the other side with the fluoroscopy. So it just means that you're thinking about it from a trauma point of view. So it's worth mentioning. Oops, sorry. Sorry, let me go back. So landmarks. So in terms of basic anatomy, the key sort of landmark is you're feeling for the coracoid process and the deltoid-pectoral groove. And it's typically sort of, and you can also, if you're going to extend, you also will follow along the lateral border of biceps brachii. In terms of the internervous plane, you want to think of the pectoralis major, which is supplied by the medial, lateral and pectoral nerves, and the deltoid, which is supplied by the axillary nerve. These are also key phrases that you need to sort of have on the tip of your tongue when talking about this approach. Now, we can talk in detail about what you actually do, but the reality is by this stage, the examiner's probably a little bit bored. So they want to know that you understand what the key problems are. So structures at risk. So one of the key first structures you'll come across that will be at risk is the cephalic vein. And I've asked a lot of my sort of senior colleagues, what do you do about it? Some say tie it off, some say take it laterally, some say take it medially. There's no real common consensus. And to be honest, for most of the times when I've done it, when you look at the cephalic vein at the end of the operation, whether you've taken it medially or laterally, you might as well have tied it off because it's been battered and bruised by the retractors. Now, the other structure risk that commonly at risk with this one is the musculocutaneous nerve. This is approximately this is a classic way of doing it, where people take the conjoint tendon off the coracoid process and reflect it down for repair afterwards. Some people even make a little drill hole in order to make a an interosseous repair. And there you can see that nerve there, okay? So these are sort of things that you need to be wary of. So again, how is it going to be injured? It's going to be injured with retractors. Now, more importantly, because this will come up in a trauma session, Viva, the axillary nerve. So this is going to might be an issue, and you can see it just here. Now, why is this an issue? Oh, sorry. Well, as we'll talk about a little bit later on, one of the things with this approach is this is where we tend to make a mistake. When we talk about this approach, we start talking about deep dissection. We've got to this point where we've exposed the capsule and subscapularis, and we're really going for it. And we're going to start talking about exposing the glenoid, exposing the joint for an arthroplasty operation. When actually the question was, you've got a proximal humeral fracture, how are you going to approach it? So in this situation, you need to stop and need to think. So we need to identify the tip, the long-headed biceps in its groove. And this will help us ID greater tuberosity and the lesser tuberosity. We do not want to describe the division of the capsule and subscapularis, particularly subscapularis, as in trauma, the lesser trochanter goes with subscapularis. So we want to protect that. We don't want to cut that. And this is for an elective surgery, not for trauma. I remember my first Viva doing this, describing it brilliantly and thinking, wow, really done it, brilliant. And they were smiling at me. But then afterwards, it dawned on me, they asked about trauma, didn't they? They didn't ask about an elective. So this is where we're going. We're looking at this bit here. So this is long-headed biceps in its groove. So this is a greater trochanter. This is the greater tuberosity. This is the lesser tuberosity. So we want to go here to fix that proximal humeral fracture. So this is where we might consider extending our approach along the lateral border of biceps brachii in order to expose it. And this is when we have to make sure that we have to be very careful with the axillary nerve, because that can be at risk at this stage. Okay, so as I say, this is just one of the things I want to make sure you're aware of when you're thinking about talking about the deltoid-pectoral approach. It is for trauma. You can talk about it in detail, but the reality is it's only going to be the last minute of your question on the Viva table. Now, posterior approach. That's a lot more popular exam question, although it's a very rare one. Why do we do it? We tend to do it for posterior capsulopathy or posterior glenoid fractures and posterior glenoid osteotomies. Very, very rare injuries that very rarely get attacked because no one does the posterior approach on a regular basis. However, it's popular because it's a test of the anatomy of the spaces and the triangles on a basic science table. So they do like it. Again, in terms of principles, we have to think of, position. So lateral decubitus position of the patient. It can follow a shoulder arthroscopy. So if you're working for a consultant who does their shoulder arthroscopies laterally, on the lateral position, so it may be they start off to a scope and then put them into this position in order to get access to the posterior part of the shoulder. It is also key when you're talking about this that you have to remember you protect the non-operative side. So lots of padding, because sometimes these operations are very long and people can get problems that one, and your anaesthetist will be annoyed. Again, this is all demonstrating that you've got an idea, you've done this, maybe done this before, and you're thinking about the patient as well as about the operation. And also make sure you position the arm and drape it so it's free, again, to allow access for x-rays as well. So landmarks. The key landmark is going to be the acromion and the spine of the scapula. So some texts talk about doing your incision going along the spine of the scapula. Others say going down. I mean, it does depend on what you're doing. If you're trying to get access to the scapula and maybe the glenoid a bit sort of more immediately, then you would go along the spine of the scapula. But a lot of surgeons, when I've seen it done, have gone down sort of in the groove, sort of axillary sort of groove in a way. Sorry, my mouse is a bit sensitive. Apologies about this. Okay. So, internervous plane. So you've now done your incision. You see your deltoid, which you're going to sort of retract laterally. And then you've got your internervous plane, which is between infraspinatus, which is supplied by the suprascapular nerve, and teres minor, which is supplied by the axillary nerve. To be honest, at this point, again, the exam is going to be quite broad because they want to know, do you know what structures are at risk? And the key thing is, the main structures at risk are going to be the suprascapular nerve, if you're ever retracting on the infraspinatus, and then the axillary nerve, because you may have identified teres major and gone into the quadrangular space. However, as I say, then at this point, this is when they start talking about the anatomy a bit more, because this is the meat of this part of the viva. They want you to talk about the quadrangular, the different spaces. So here's a nice sort of picture. So we've got our triangular space, our quadrangular space, and our triangular interval. They do love this because it's quite easy to get these all confused. So I'm going to start off with the triangular space. So this is the most medial of the spaces of the intervals, and the boundary superior teres, the inferior border of teres minor, inferiorly the superior border of teres major, and then laterally is the medial border of long head of triceps. It doesn't sound great, does it, when you say it like that? But those are the key sort of things that they're going to be interested in. And contents, circumflex, scapular, artery, and vein. And this is important, particularly if you're trying to treat any injury around the scapula. Again, it's more of an issue, as I say, for anatomy as a point of interest. And you could quite easily have a picture of the dissection section to show you. Okay. Then the next one is going to be the quadrangular space. So the superior border is the inferior border of teres minor. The inferior border is the superior border of teres major. As I say, it does sound a bit of a mouthful. And then medially, you've got the the lateral border of long head of triceps, and the lateral border is the shaft of humerus. The contents are the axillary nerve and posterior circumflex, artery, and vein. This again is important, particularly if you're doing a posterior approach. So this is where the temptation is. You've seen what looks like teres minor, and you've gone in for it, and that you've made your interval there rather than there. Okay, so that's when that nerve can get injured. Now, the last interval is going to be the triangular interval. So the key features are to think of the superior border. This time is teres major, the inferior edge of it. Medially, again, it's the long head of triceps, and laterally it's the shaft of humerus. The contents are the radial artery and profunda brachiae artery. This becomes more important when you're doing a posterior approach to the shaft of humerus, and is a good way of identifying where your radial artery starts before you sort of start developing your plane deeper. Okay, right. So, sorry, that was a little bit briefer than I thought it would be, but any questions that people would like to ask?
I haven't received any questions, David.
Okay.
I think there was a question about the radial nerve from Amjad, and I'm not sure what exactly he wants to know, but possibly I presume you want to know the course of the radial nerve, and I wasn't sure if it was part of your talk tonight.
Radial nerve and radial artery.
Sorry?
I think you misspoke. You said radial artery.
Did I say radial artery? I meant to say, so where are we? Let's go back. Previous, sorry, Encho. Let me go to that there's a better picture of it. So here we are. So if I put this back on the screen. So you can just sort of about see it here, radial nerve. So this is the triangular interval. And so it's coming inferior. It's coming from just below the inferior edge of teres major towards the shaft. So it's going from medial to lateral, and then you'll start the spiral groove. Sort of starts about there, and it's underneath the. Was it the? Trying to remember. It's not long-headed, but triceps. It's lateral-headed triceps. Sorry, lateral-headed triceps. So it comes in underneath lateral-headed triceps and into the spiral groove, sort of just roughly where my arrow is. And then here is the profunda brachii artery, which will follow the neurovascular bundle there, and that wraps around to the front, as you would sort of, in terms of anatomy.
Yeah, thank you, David. I think I'm just trying to say, I think in the presentation it says artery instead of nerve.
Oh, did it say artery? Apologies.
But we all know what you mean.
I apologize. I misspoke.
No, that's fine. Good, excellent.
I'm not quite. I'm not doing George Bush, but I did speak then.
You're doing very well. Excellent job.
I think it's very good.
And I think that David's covered very nicely the excellent and very important exam topic, approaches in general, how to answer any approaches question. He covered all the main components of how do you answer if you ask about any approach, how do you explain the indications to the examiner, the positioning of the patient, the landmark, your incision, your internervous plane, and the anatomical hazards. And his presentation could be used like really as a guide to answer any question about approaches. An approach, particularly the deltoid-pectoral approach, is very commonly asked question. So I think that's, and then if you get asked about the spaces in the shoulder, that's also very nicely covered here, and you can explain them very nicely based on this talk.
Yeah, so I just want to stress, I mean, in terms of, we get very worked up about anatomy and approaches for when we come up to the exam. When reality is, it's quite simple. I made this mistake at the beginning, so I was trying to recreate Hoppenfeld word for word, when reality is you don't need to do it. You don't have time to do it in the Viva section, or in the, if you get to the point in a short case or a long intermediate case. These are the key things that the examiner wants to know. So position, landmarks, internervous or intermuscular planes, structures at risk, extensile, and any sort of tips. As I said, I would recommend Alex Trumpter's little book on trauma with the FRCS. It has all the major approaches that you'll need to know in this situation. It's only it has all those major approaches, maybe on 4 or 5 pages. So that's all you really need to know. So you don't have to be so descriptive as we end up being. As I say, it does. You can overdo it, and you only have a short space of time. You want to do it maybe in 30 seconds to a minute, and if you can get all of that in a minute, you've got all the marks you're going to get on approach.
Great. I think we had one question from Usman, and I think it's quite an advanced question. I think if you get asked this in the exam, you'll be doing extremely well.
Yeah, I think it's from the superior margin of the margin of the pec major. As you mentioned, this is quite advanced question. If you are getting that question, either you are doing very, very well, or you are doing very bad.
Yeah. So what's your answer again, Kashif? How would you?
It's a superior margin of the pectoral major. So yeah, I think it's 2.5 centimeter. I think as long as I can remember.
So you'll use the superior margin of the pec major as your landmark, basically.
As your landmark. Yeah. And height of your implant should be 2.5 centimeters superior to that, if I'm not wrong.
Oh, is this for use of proximal humeral plate?
No, it's not for. It's for the replacement, humeral head replacement.
Oh, humeral head replacement.
Yeah, if you're doing the orthoplasty, how you are going to judge that you are a position of the humeral head at a correct level.
Correct level.
So he has mentioned for the hemiorthoplasty. Usman has written for the how to judge the implant when you're doing the hemiorthoplasty of the shoulder.
You will unlikely. Yes, that is a very advanced question. You're unlikely to get asked that question in the exam.
No, yeah.
They want. The reality is you've got to. If you can understand the principle that sort of the retroversion of the humeral head or the position of the glenoid. That's more important, I feel. But yeah, and some implants have got different specifications as to where they go. So I know there'll be a bit of an argument from the point of view of the shoulder surgeon as to what position it should be. But roughly,
I think I think I found the answer. I think the distance from the top of the prosthesis to the upper border of the pec major should be 6 centimeters.
6 centimeters, yeah.
Yeah. So 2 inches and a bit.
But just from the insertion of pec major.
Yeah.
Superior margin of the pec major.
Yeah. So thank you for that question. I think, is there any more questions from participants? These are all the questions I received. Anyone from the mentors would like to add anything?
Just to reinforce David's last point, which I think is incredibly valuable, and I think you guys need to take this on board. His headings are perfect. Just reiterate your heading in a fully consented, marked and appropriately consented marked patient with anesthesia on board. My position is, my landmarks are, my structures at risk are. Just hit them with those. Sorry, I apologize. The internervous plane is, my structures at risk is, and so on. Hit them with those points, like bullet points. Don't bother trying to have a conversation. Just hit them with those points, because the marking is in that. Once you get to the tips and techniques part, you're now in the discussion about what you do really in the operation and what to watch out for, what are the other things to do. So David really highlighted that really well. I just want to make sure everyone pays attention to that part.
Yeah, but that's the team needs to be used.
We do that later.
Yeah. So yeah, we'll do that later. Yeah.